Because the stomach wall is thick.
Yeah,
And,
yeah.
Are you crazy? You're making a hole in the stomach and in the liver. So hi again for the next episode, Endoscopy Essentials. We are still fighting with hepaticogastrostomy with Takao Itoi from Tokyo. Welcome back. So we are pretty far. We have guide wire inserted, and then it's about stenting. One general question beforehand, because I've seen this occasionally. Is it necessary to have a stent in every case? So if you have a stone case, and I've seen you and others, you do a balloon dilatation of the papilla, stones are out. Can you really pull out everything? Or do you leave a stent for safety even for benign indications?
Yeah, good question. So I always press a stent because in some cases, if we stone completely push out into the into the duodenum, but so sometimes the residual stone is present. So later we realize by CAT scan, and we have to back.
And the access is gone.
Exactly. And the one is so for the re-intervention, and the other is to avoid the bile leakage. So there's two reasons to press a stent. Yeah.
But bile leakage is also a very important thing because there is some likelihood if you pull everything out. Huh? Okay, always a stent.
Yeah.
And then, but then there is a choice between plastic stent and metal stent. So what is your approach? Metal is for malignancy, plastic for benign, or is it not so easy?
Also, good question. So later I'd like to explain that basically I love plastic stent because we created a dedicated plastic stent for HGS. That's why, and in particular for the beginner, maybe plastic stent is much easier than metal stent for deploying the stent.
So it's usually 7 French?
7 French and 8 French, but 7 French is much better.
It's 7 French plastic stent. So one question, if you decide to be on the safe side, a primary plastic stent, if you want to go back and you know, okay, now I know it will be a long-term drainage, how easy is it to exchange the stent after, let's say, 2 weeks? What happens if you pull a plastic stent out? Do you find the orifice or is it difficult?
It's also very important, very good question. So maybe, so usually it takes 2 weeks to create the fistula between the stomach and the liver. That's why, so less than 2 weeks, maybe no creation of the fistula, no mature, immature. That's why at that time, so stent keep, and alongside the stent, the guide wire insertion.
Alongside the stent.
Alongside.
Okay.
So that's why, many years ago, we removed the stent. And so cannot.
And you don't find it.
That's why I couldn't.
Because the stomach wall is thick and it's gone.
That's why. So always,
okay.
Always a stent placement and alongside.
And which scope? A duodenoscope then?
Duodenoscope.
Yeah,
Duodenoscope.
Okay. But they have a different angle. Okay. Duodenoscope then.
Yeah.
But never pull the stent out too early.
Never.
Try alongside.
Yeah, exactly.
Okay.
Yeah.
But could that not be an argument for if you, at the primary intervention, it's a malignancy, and you feel, okay, probably the end result will be a metal stent. Would you then not primarily place the metal stent?
Yeah. As I mentioned, for the beginner, the stent, so collectively stent placement and the reliable stent placement is plastic stent is much better for them. for the expert, the metal stent deployment is not so difficult. That's why either is okay.
Either is okay.
For the beginners, if during the ERCP, if so, they can do double pixel stent placement transpapillary. If so, maybe the plastic single pixel stent is very easy.
I see.
Yeah.
So okay, you're on the safe side in the primary intervention.
Yeah.
One question comes to my mind when we started this. There was a big resistance from surgery. They said, "Are you crazy? You're making a hole in the stomach and the liver, and when we do surgery, it's impossible." And what's your reply?
It's also very good point. And actually, so we published a paper about the preoperative HGS, and so using a plastic stent. So fortunately, our surgeon said, very good technique. Very good salvage treatment in case of the gastric outlet obstruction cases. Usually it's a PTBD, but so internal drainage and so no obstacle for the operation. Interestingly, for example, pancreatic duodenectomy, at that time, so extrahepatic bile duct cut, and they can see robotic or laparoscopic. So they can see the distal side of the plastic stent. So easily removed from the extrahepatic resection site. And so we can see the video always very easy by surgeon from the stomach to the.
So maybe, I think there are probably different opinions, but maybe this is an argument for the plastic stent if there is surgery, because obviously at least you surgeons feel better if they see the plastic stent and the hole is not so big. Okay.
Yeah.
Good. So, but explain us how you select the stent and place it in detail.
Yes, thank you so much. So as we discuss about metal or plastic stent for HGS, they have each advantage and disadvantage. For example, the metal stent, so minimum bile leak after placement of stent. Of course, during the procedure, sometimes the bile leakage happen. But after correct replacement, minimum no bile leak. And of course, better patency. Patency is much better than plastic stent, but difficult stent deployment due to the shortening of the metal stent. And sometimes the overdilation causes the cholangitis, segmental cholangitis. The small bile duct, peripheral bile duct, and usually the metal stent edge of the metal stent causes hyperplasia or something, and so close easily, and so cannot remove if we need necessary at that time. That's why the metal stent has advantage and disadvantage.
But there are usually metal stents which are covered mostly, but the edges are free.
Yeah,
both sides are uncovered.
So called the end cover, end bare type, partially cover. Mostly the cover and the liver side. Only liver side 1 cm or 2 cm are uncovered. Metal stent. In contrast, the plastic stent, so fortunately we created a dedicated stent. So if we use it, easy deployment, very nice straight single pigtail. The pushability is nice, and the stent, if necessary, we easily remove the stent. Of course, some endoscopists worried about the bile leak over dilation, tract dilation, and press this 7 French plastic stent. But so I don't think the main reason of unlike plastic stent, because we always if we perform a PTBD, usually so over dilation and finally 7 French or 8 French tube, PTBD tube.
By the way, again, this question, how do you prepare the stent placement? So if you want to place a 7 French plastic stent, then you have your mechanical dilator, which is maybe, I don't know, 6 French. You place your guide wire in a secure position. How far do you go to, how far do you dilate the duct if you want to place a 7 French stent?
If we want to place a 7 French plastic stent, so usually it's a bile duct. So bile duct wall, so want to bile duct hole, puncture side, only puncture side up to 7 French is enough. Not so
dilation.
Dilation.
And you do it with a second mechanical dilator of 7 French or with a balloon?
7 French.
7 French.
Mechanical dilator.
Okay, and then the stent. And to prepare for metal stent, what do you do?
At that time, so we use additional dilation is necessary. That's why so dilating balloon.
Which diameter?
Up to 4 millimeter in there.
4 millimeters.
4 millimeter.
And then the stent diameter is?
Stent diameter is it depends on the bile duct diameter, intrahepatic bile duct. Usually,
what choices do you have?
8. 6 or 8.
6 or 8 millimeters. Okay, but then you do a balloon dilation with 4, and then you can get your stent in before it deploys. Okay, good.
And so last the issue of stent patency, we have to talk about that. So somebody may think plastic stent patent is very short. But so if we can place easily a plastic stent for HGS, I think it's very important rather than patent. If we create the fistula safely, if we create if we place a stent safely, so it is very important. So to make creates a fistula. After that, we can change easily.
I see. So if you go for safety first, it's in favor of plastic stent, and then you have something, and then you can think what it's long term. Will the patient undergo surgery? So you have all options.
Exactly.
With a metal stent, you must be pretty sure that there will be a metal stent forever, and it's more difficult.
Correct.
Okay.
So this is our invented plastic stent.
This is your special plastic stent.
IT stent. So Itoi Takao stent.
IT.
Sorry.
Which is it available everywhere?
Now the only Taiwan. This year Thailand. I hope not only Asia but also the Europe.
And US, so
it's
it's slowly progressing towards the West. Okay, good. It looks good.
It looks good, and a very nice flange, and to avoid the migration, and the single pigtail, and also the integrated all-in-one is much better. Otherwise, separate the pushing catheter and the stent. So if we fail, no choice. This is can easily remove if the very difficult hard bile duct.
Okay.
So looking at the metal stent, so nowadays we use this kind of 4 types in Japan, and the very important point is delivery diameter. Another benefit is only 6 French, very small. Very easy to pushing into the bile duct, but so fully covered. This is fully covered means no anchor. Partially covered, so has usually as an uncovered portion. That's why.
And
so
also, if you have the uncovered portion, it can go a little bit deeper into the bile duct
yes,
because you are not afraid of the side branches so much, right?
right.
And the fully covered, it's probably sometimes a bit tight, huh? Yeah. So there's no ideal stent, and
Yeah.
the foreshortening is also a bad thing, huh?
Yeah, that's why. So available stent in Japan, almost all shortening happen.
Mhm.
That's why. So we are afraid of the adverse event unexpected. So we usually use this type, partially in the bear and the 8.5 range, 8 millimeter in the meter. So why so worried about so risk of migration of a braided type? So already is a paper many years ago. So after 5 days, the gastric side migrated into the abdominal cavity, and this is a fatal case. That's why I have to avoid this migration.
If you see your stent is too short,
Yeah.
or it's likely that with further shortening it migrates out, can't you put a second stent?
Of course, during the procedure,
Yeah.
of course, add additional
Uncovered then.
uncovered,
Uh-huh.
uncovered, or
Yeah.
yeah, and
Which
if,
you should probably think about, you know, if you have just one remaining centimeter in the bile duct
yeah,
and you foresee some shortening, you should do something
yeah,
right away. Otherwise, this happens.
exactly.
Mhm.
That's a big problem.
Okay.
That's why, if possible, hopefully the uncover end bear, partially covered, and the laser cut were anyway. So non-braided type, non-shortening type metal stent is much better. One of option is this biliary is not available in Japan, but so
Gore-Tex.
yeah.
They're making clothes, huh? For Amazon.
And so this has it has anti-migration system. Fin
Mhm.
is one of a good option.
So that would be your preferred stent
Ah,
for this, if you could get it.
if we use so this Bible is most favorite for me. Yeah. But so in terms of the whole stent, as I mentioned, plastic stent is to create.
No, we get the message: be cautious with metal stent, and rather place a plastic stent first. Right?
Right.
Yeah. Okay.
So
Good.
this is the last slide. You know, in case of the migration, we worried about. That's why. So we have to place. We have to use when we use braided type stent. We have to take care of the gastric side stent length. Usually more than 3 or even 5 cm. Longer is much better. That's why. So if we use a braided stent, usually the total length of stent is more than 10 cm or even 12. Longer is much better.
Much safer.
Much safer.
But it's not ideal. So I understand we do not have the ideal metal stent.
Exactly.
Because you are planning for shortening and you're making the stenting too long, hoping that it will shorten. So it's kind of, yeah, I get, I think we all get the point. Yeah. So now you have your, let's say, plastic we have discussed, you have your metal stent in place. What's your experience? Can this be a very long type of stenting for benign indications? Sometimes patients with strictures, they have their PT, their percutaneous drainages for many months or even years. Is that a long-term option? What experience do you have?
Long-term placement.
Long-term placement.
Long-term placement. Usually we lab the metal stent for the stricture site. Yeah, And this is just hepaticogastrostomy. So after creation of the fistula, we can easily do antegrade intervention. At that time, so in case of the stricture, in particular benign stricture, so we place HGS stent and remove and the antegrade stenting, antegrade or intervention. That's why. So in case of benign cases, we place a long time stent placement, HGS. For example, most longest HGS stent is more than 3 years.
It's basically, I mean, it's the same concept like with percutaneous drainage. You have an access, so you can go in again and dilate and do whatever you want, and it's just internalized. So now you have an internal access where you can come back and do repeated dilatation. Do you do that? Yes.
Yeah. Okay. Exactly.
Yeah.
Yeah. Just keep the fistula.
Yes.
Yeah.
By a metal stent.
Exactly.
And any experience after 3 years when you take the stent out? What happens? There's a permanent fistula, but it doesn't matter.
Yeah, it doesn't matter. But so spontaneously, so self-removement. So 6 months later, no stent.
Stent is gone. Yeah? But there are usually no problems.
No problem. Interestingly, yeah.
So the body takes care of itself.
Exactly.
Okay.
No need.
Yeah, no need. Oh, very interesting. So Takao, I'm so grateful. I learned a lot, and everybody else as well. I thank you so much for these 3 fascinating episodes, and I hope to have you back for another fascinating topic in the near future. Thank you.
Thank you so much.